So there's been a lot of discussion recently about the role that artificial intelligence and machine learning is going to play in healthcare. People are asking, is it going to replace doctors? Are radiologists going to be out of a job within the next few years? And a lot of heavy hitters have weighed in and said that they think machine learning is going to replace doctors in some sort of capacity. And I think it's a really interesting area of discussion. It's something that myself and some colleagues wanted to explore. We did this study where we looked at all of the papers that were comparing artificial intelligence algorithms to doctors and tried to understand what sort of conclusions were they coming up with, and basically what the current state of affair is in terms of research and evidence behind the use of AI algorithms to perform medical tasks. After publishing a paper on this a couple of months ago, I was invited to give a talk basically summarizing the findings of this paper at a meetup in London called London.AI. And I was super excited by this because this is one of the main artificial intelligence meetups in London. So it's a really awesome opportunity. Because of coronavirus, everything is being done remotely. It's normally a in-person event, but instead we did it remotely and we live streamed over Facebook and YouTube. So this video is basically, I just wanted to share that recording. It's about 15 minutes for the talk and then 5 or 10 minutes of questions afterwards. And they ask some really interesting questions as well. So if you're interested in artificial intelligence and the role that it may play in healthcare, then hopefully you find this interesting. And if you're based in London and you're interested in artificial intelligence, then I think the London.AI was a fantastic meetup to go to, particularly once this coronavirus situation has resolved a little bit more and people are able to go to in-person events, then I would highly recommend it. So without further ado, this is the talk from London.AI. I hope you enjoy it.
So I'd now like to introduce Chris Lovejoy. He's going to cover topics in medicine because he comes from that domain. He's a medical doctor, senior house officer in the NHS, and former clinician, data science, and technology lead at Sierra Care, which is a London-based startup. And he also trained in machine learning at UCL. In particular, he'll be presenting around some recent work that he and colleagues have published, which really looks at clinical applications of deep learning in medical imaging and studying some new findings that we can infer from those by looking at them as a group. So over to you, Chris. Thanks a lot for joining us.
Okay, thank you, Nathan, for the introduction. So, as Nathan said, my name is Christopher Lovejoy. I'm a junior doctor doing research in applications of machine learning in healthcare. And today's talk is going to focus about a recent research study that myself and some colleagues did, where we appraised different studies that compared AI performance with clinicians, and also touch on some of the wider questions around the role of AI in healthcare and the kinds of things that this research raises. So to begin with, I just wanted to share a few of the kind of perspectives at the moment on the role of AI in healthcare. So on one side of the fence, we have a lot of prominent figures in AI and in machine learning saying things along the lines of, in the top left here, Geoffrey Hinton saying that he thinks radiologists will be replaced in a few years' time. He said this, I think it was around 3 or 4 years ago. So, and then in the bottom right here, this is a blog post written by Vinod Khosla, who's a prominent investor in Silicon Valley. And essentially his conclusion or his thoughts were that by around 2035, he thinks about 80% of doctors will have been replaced by AI. And then on the other side of the fence, we have people making the claim, making the point that perhaps AI is going to be more about supporting doctors. Maybe it's going to be doing a lot of the repetitive tasks that doctors have to do and free up their time to do other things. So on the left here, this is a book by Eric Topol, who was one of the co-authors on the paper. And in this, he makes the argument that AI will enable us to have the time to foster the doctor-patient interactions and ultimately kind of rehumanize healthcare is the argument that he makes. And on the right here, there's a couple of research articles also making similar sorts of points. So the purpose of our study was to critically assess the studies that have been published so far and see what sort of claims they're making, seeing how valid those are and how much the kind of science supports those, what sort of methodology they followed. And we asked 3 main questions as part of this study. We asked what types of studies have been done, how well were they done, and how well were they reported. So in terms of the first question, what types of studies have been done? To give a little bit of context for those not familiar, the gold standard level of evidence in medicine is the randomized controlled trial. And basically what this involves is you take a population, you divide it into two, you do two different interventions, and then you measure the outcomes and compare those outcomes. So in the context of applying an AI algorithm to healthcare, on the screen, this is an example of a study that has been done, which was the group took some people who needed colonoscopies, which is where you put a camera into the colon to try and identify polyps that might be cancerous. And what they did is they had a human performing the colonoscopy and looking at these lesions, but then in a separate room, they had either a doctor or an AI algorithm reviewing the images at the same time. And if the doctor or the second doctor or the AI algorithm flagged up a potential lesion, then that would get fed back to the doctor. So the person performing the colonoscopy didn't know if it was coming from an AI or a human. They then measured the rate of polyp detection and kind of reported the performance. And in that case, it was the case that there was more polyps detected by the AI. But essentially, this is very much the gold standard because you're taking out any of the potentially confounding variables. You're directly comparing two things side by side. And kind of more broadly, you have prospective studies and retrospective studies. So retrospective studies is where you are training your model on data that already exists, and then you're testing it on data that already exists. Whereas prospective is you train your model on the data that already exists, and then you collect data in real time and analyze the performance of the model on that. So an analogy might be, you might train an algorithm on, let's say in the stock market, you might analyze on all the existing stock data that you have. And if it was a retrospective study, you would then test that performance on the existing data, although obviously you'd probably keep a subset of it apart to try and test the performance. Prospective would be testing things going forward. And you typically see a drop in performance when you go from a retrospective study to a prospective study. And there's several examples of this in healthcare. So there's a prospective study for breast cancer screening, which then when it was done prospectively, it didn't see the same positive impact. And a similar sort of study in childhood cataracts as well. So when we then came to look at what studies have been performed so far, looking at deep learning in healthcare, we found at the time of our study, so this was closed last year in June 2019, we found that at that time there were only 2 randomized control trials, and there were 9 prospective trials out of 81. So now there are more. So as I understand, to my knowledge, there's now up to 6 randomized control trials, which are shown in this table on the right. But ultimately, it kind of points towards relatively weaker evidence to support the kind of abilities of these AIs and the comparisons with clinicians, and kind of points towards just being fairly early in the development of this kind of research field. And I think it makes sense because obviously deep learning is a relatively recent field. There's always going to be a lag once you have that technology to then build algorithms to be used in healthcare and then run those trials, etc. So probably with time, I imagine this will catch up and we will start to see more and more randomized control trials and prospective trials going forward. But ultimately, that's kind of like a reflection of the current state of affairs. So the second question was, how well were these studies done? And there were 2 main weaknesses that we identified in the methodology of studies that have been done so far. The first of those was that, on the whole, the clinician control group tends to be quite small. So the median number was 4, the interquartile range was 2 to 9. And some studies also reported non-experts and kind of averaged the performance between the 2. And I think one reason why we're not seeing a huge number of clinicians in these studies is the fact that it's very time-consuming to recruit clinicians and to test their performance, because when you're doing deep learning studies, you're typically looking at a very large number of samples. But ultimately, it can weaken the conclusions because you can expect a degree of variation within clinicians, and particularly if you kind of dilute the performance with non-experts, then that's going to affect the ability to make claims of the AI being kind of comparable or superior to doctors on the whole. And the other thing that we found, so we used this tool called the Probast, which is a tool for assessing the risk of bias in studies that are trying to perform diagnosis or prognosis. And essentially, it's a list of questions around the different methodology approaches that were used in the study. And we found that of the 81 studies, there were 58 that were ranked according to this as having quite a high risk of bias, and particularly poor performance was on the analysis section. So there's a couple of sample questions from the analysis here on the slide, and the ones that we typically saw they didn't perform well in was sometimes the sizes of the data sets weren't huge, and they often didn't really take measures to prevent overfitting or kind of comment on the risk of overfitting. But this all just points towards the quality of the study designs not being extremely high, and therefore there being quite a high risk of bias. And one potential kind of contributing factor to this is because AI being applied to healthcare is quite an exciting field. Maybe there's a kind of degree of the publishers wanting to publish these kind of papers and maybe lowering the threshold a little bit, or maybe just the methodology is not kind of fully standardized yet because it's still a relatively early stage in the field. So the third question we asked was how well were the studies reported? The first finding was that using a tool to assess this called the tripod, on the whole, the adherence to the reporting standards was quite low. Essentially, this is similar to the PROBAST. It's a checklist, but this one looks more at the study methods themselves. Sorry, the reporting of the study. And there is a bit of a caveat in that this tripod system, this tripod checklist, was initially devised for regression models. So it tends to kind of lean a little bit towards that, and some of the questions are not super relevant to deep learning. But we did account for that in the study. So, for example, there's some tripod questions about the predictive variables, which actually in deep learning of medical imaging is less relevant. But what's happening at the moment is the research group that devised the tripod are currently devising one specific to machine learning, with the hopes that that will kind of standardize the research methodology approach and the kind of reporting standards in these kind of studies. And then the second thing that we found on the reporting point of view was that the code and the data that was used in the study tended not to be available. Obviously, there's a challenge when you're doing kind of AI studies in healthcare because it's a relatively novel paradigm for healthcare to have code as being a kind of central part of the study. And there is understandably some resistance to want to share your code, because if you're an organization that is running a study with the hopes of commercializing that, then you might not want to share your kind of intellectual property. But one of the kind of fundamental tenets of medicine is the reproducibility of the studies. So we would like to have code and data being available so that somebody else can theoretically recreate that and just make sure that they find the kind of same sort of outcomes. So in terms of just kind of drawing a few conclusions on this study, I think the main takeaway is just the fact the state of research is relatively early of applying AI to healthcare. We still need a lot more studies going forward that are prospective and are randomized controlled trials. And those studies, we need kind of good quality design of the studies and also reporting standards. And hopefully with new guidelines and more guidance on this, then we will see that kind of improvement in that quality. I think there are a small number of cases where we can confidently say that AI performs better than doctors, but often it's in the case of AI in a role that assists doctors rather than replaces them. So for example, the polyp detection algorithm I mentioned earlier, in that case, it is the case that the AI as a second screener of the polyps performs better than having a doctor as a second screener. And probably that's due to the fact that the kinds of things that the AI is good at picking up is slightly different to the doctors. And it was the case that when they interrogated it, it seemed to be that the kind of smaller and flatter polyps are the ones that the AI was able to detect. But ultimately, we should just kind of strive to be careful and like quite objective with how we explain the current state of affairs. We found that in the 81 studies that we looked at, 23 of them claimed superior performance to clinicians, but they were retrospective studies and they didn't mention caveats like the need for prospective testing. And some of them said that it would now be appropriate to kind of do clinical implementation of these algorithms. And if we do allow ourselves to kind of use overpromising language without the appropriate caveats, it can contribute to hype and perhaps unrealistic expectations on the current state of affairs of applying these algorithms in healthcare, and maybe potentially mislead the media and the public to some extent. So that's it's an important consideration to make. And the other thing as well is about the way in which we frame the question of is it kind of AI replacing doctors, or is it going to support doctors? Right now, it seems that the studies that are doing well are ones more in a supportive role. That's not to say that AI isn't going to be able to do some tasks that doctors kind of currently do as a primary task. But obviously, despite this, I know that generally the findings of this study were fairly critical. I would personally say I am pretty optimistic about the potential for AI to be used in healthcare. I think it's only a matter of a year or two before we see lots of exciting applications of AI in narrow domains within healthcare. I think it's just a reflection of the state of affairs, which is that we're a relatively early state kind of within this research field. And hopefully in a year or two's time, we'll see a lot of these kind of narrow domains being supported by strong evidence and better patient outcomes as a result. Just to close, a couple of references. So the top one is the reference to this original paper. Twitter, one of the co-authors, Eric Topol, is very active on Twitter and shares, if anybody who's interested in AI studies in healthcare is very active. It's a bit of a treasure trove on like what's going on right now. There's a blog here that I'm a big fan of by a radiologist and a PhD student called Luke Oakton-Rayner, and also share a few articles about machine learning in healthcare as well on my personal websites. So thank you all for listening, and if there are any questions, I'll be happy to answer them now.
Chris, thanks a lot for this presentation. Just jumping in with the first standard and obvious question, but if the community wants to help or get involved, what's the easiest way of doing so?
When you say community, as in?
Yeah, sorry. So the usual members who attend London.AI.
So I guess, yeah, it depends. It depends what your background is. If it's more of a kind of technical background, then probably the best ways are, I think a lot of these studies ultimately will require collaboration between clinicians and between people who have deep understanding of the kind of AI technology behind them. Because one of the issues is obviously if it's a clinician leading the study, then they need to have, they're not going to have the appropriate insight into the ML side of things to fully take into account risks such as like overfitting and just the different aspects of the study design from a machine learning point of view. And likewise, someone purely with a machine learning background won't have a strong insight into the clinical aspects and some of the nuance around that. So I think fundamentally it is a collaborative effort. So the key thing, I think, for establishing that collaboration is if there is anybody who wants to collaborate on these sorts of projects, then just looking out for opportunities at research groups at like the universities nearby or local hospitals, and trying to see who's active in that space and just setting up collaborations with them, I think is probably the best route to take.
So, Chris, like in the last, say 12, 18 months or so, the US FDA has issued approvals for maybe 4 or 5 or so medical imaging products, ranging from kind of the broken wrists or I think something to do with cardiology, and perhaps another one to do with ultrasound. Have you seen post-FDA approval an uptick in adoption of these tools in clinical practice, or is this like holy grail of FDA approval just the tip of the iceberg with regards to driving adoption?
Yes, so the current kind of level of evidence that's required for FDA approval is the retrospective studies. So you don't have to have a prospective validation or a randomized controlled trial, like I mentioned. And so there are a lot of things that have been approved by the FDA and that have had uptake on a pretty wide scale. and are not yet prospectively validated. And I think the kind of key thing here, and what's slightly tricky, is obviously we don't want to kind of stifle innovation and stop people from developing these algorithms and implementing them. But we also obviously don't want to risk patient safety. So there are a lot of cases where, we have these algorithms that have been developed and they're now kind of in use. But I think in those cases, it's always done in a fairly kind of safe and cautious way, and always with a look to then develop prospective validation, because once it's got that approval and then you're doing these studies in the real world, you'll quantify the performance and then report that. And I think that's like a really key part of it, is that's made for that. But also when you look at a lot of the tools that have been FDA approved and are in use, they are typically more in roles such as like triaging, for example, where they're not having a direct decision, in a sense that they're not making a diagnosis of one thing or another. They are maybe triaging a scan. So for example, Viz.AI have an algorithm that looks for the presence of a stroke. And the idea of that is it flags that up and will then kind of alert clinicians to potentially save time. And there's a similar algorithm as well for triaging chest x-rays, so that chest x-rays get reviewed more quickly. But in that case, if you're leading, the risks of like mis-triaging that are relatively low, because if you triage a scan, it gets reviewed earlier, and actually there wasn't really anything on it, then there's not really been any harm kind of come as a result of that. Whereas if it was something more about maybe making a diagnosis and then there's not a second person looking at that, then there's like a higher risk there. So.
Yeah, and then one of the topics that that Luke, whose blog you listed on your talk, is mentioned in the past that I thought was quite interesting, was the kind of broad quality, so to speak, of the labels that are usually added or appended to images that are then used for training machine learning models, especially in computer vision. Some examples of researchers appending labels to images that you couldn't derive solely from those images, and so you get a model that's predicting conditions you can't diagnose from the visual data alone. So to what degree did you look at, or do you have a sense of whether like labels that that clinicians are using in these studies are actually of high quality, or if we still have big problems there and should be enforcing standards?
Yeah, so it's not something that we looked at specifically in this study. I am aware of certain data sets in particular, kind of where these sorts of concerns have been raised. And there's not really like a hard and fast rule on it. I think in general, is kind of encouraged to, if there are any concerns about that labeling, the labeling of the images in that data set, to then go away and maybe relabel it. And there are cases where groups have published studies using a data set, and then they've gone back and kind of relabeled it, rerun the model. So yeah, I think definitely that it's a very important consideration, because obviously the algorithm is going to be as good as the data. From the point of view of having information that's not necessarily available from the scan, sometimes that can actually even be helpful. Like because then you can actually define a kind of like stronger ground truth. Because let's say you have a picture that looks like a tumor on a chest x-ray, and then you send that away and you had like a definitive diagnosis from a biopsy. That can actually be quite helpful, because you are giving the algorithm an advantage in that the human interpreting it won't necessarily have that outcome known, but just by kind of reinforcing that ground truth, there's the potential for the algorithm to actually then perform even better if it's able to recognize some sort of pattern that enables that to be predicted.
And we saw in Mohan's presentation a lot of components that one can add to an overall system design with regards to safety critical tasks. So to what degree are you seeing a push for interpretability of AI solutions in medical applications?
Yeah, so definitely there is a kind of push towards it, and we want to kind of be able to identify that, and that's something that obviously regulators are going to value highly as well, because again, as the same sort of issues that you really don't want to be making mistakes. So when something does go wrong, you want to be able to interrogate it, and ideally you want to interrogate that like when it's still in a in silico context, and not when it's actually something that's being applied. And that is something that's been interesting. Like in a few of the kind of like landmark studies, there was a kind of study from Stanford a couple of years ago looking at chest X-rays. A big part of that study, the aim was to be able to diagnose based on the chest X-ray, like various different pathologies. But one big part of that study was a kind of heat map to show where the algorithm was looking, what areas of the chest X-ray were important for making the diagnosis, and so that sort of thing can be helpful as well.
Cool. I think we have one last question, which is, if we look at some of the work that, for example, Alex presented from self-driving, it seems like this has been a huge amount of development in various computer vision techniques that are becoming increasingly kind of general purpose for different data domains. And so some of us are curious around how much of the innovations in computer vision in different fields can be directly translated over to medical imaging, or to what degree does the kind of data that you work with in medical imaging demand different architectures or, different loss functions, et cetera.
Yeah, I think on the whole, it seems that it is pretty transferable. So a lot of the big studies that have been done in medical imaging have not made huge numbers of modifications to kind of existing algorithms from other domains. And it tends to be, because there is a bit of a lag within this application of AI to healthcare, it tends to be the case that advances in AI algorithms that were done elsewhere are now just being transferred without too much modification to healthcare. And there's nothing that I'm aware of where anybody has kind of majorly redesigned kind of like algorithmic approaches to apply to healthcare. I think we're still at the stage where we can just apply the current computer vision technology, and that's not the limiting factor at the moment. The limiting factor is more things like data sets we can then train the data on.
Great. Well, Chris, thanks a lot for a really interesting presentation, and thanks as well to other speakers.
So that was the talk that I gave at London.AI. I hope that was interesting. If you have any questions, feel free to leave them in the comment below, and I'll see you in the next video.